Well, thank you so much. I'm delighted to be here, and I understand that we have a combination of both in person as well as everybody in the ethos and the iCloud. So who I can't see, welcome, and take notes. And I'm here to answer questions, and you're here just as much as you are here physically. Okay. So. I am going to talk about perinatal genetics, and I understand that the majority of you are pediatricians. Yes, okay, or family practice, but yeah, pediatricians. And I think that hopefully I will be able to present to you that what I do these days as a perinatal geneticist in maternal fetal medicine is that I now live the entire full circle of life. So when we talk about prenatal diagnosis, I hope that I will convince you that I have no idea where that begins these days. Okay. Next slide, please. So I have zero relevant financial relationships with anybody. Next, please. So I give this talk a lot, and I always start with this slide because I've been working as a perinatal geneticist since 1979, at a time where we literally just discovered karyotype and banding. I'm a little bit of a dinosaur, and in college, my thesis, the thesis that was question that was handed to the seniors for graduation in genetics, which is what I majored in, was what propose a mechanism for X inactivation. So that was not that long ago, and you're looking at somebody who's still alive and relatively relevant. And I spent most of my time doing maize and Drosophila genetics. So from there to human genetics and where we are today. So I'm constantly humbled by the warp speed of science and technology. And I also really want to impart on the point that fetal investigation could not happen, that there are two lanes really in fetal investigation, and that is that it allows us to access, all the technology that has been developed over these decades to allow us to access the fetus either directly or indirectly. But it has to be in parallel with all of the molecular, the scientific, biological discoveries. I realize that in this generation, I'm looking at all of you guys, that PCR is, but I remember when PCR was discovered or invented, and we all kind of went, oh my gosh, we went to Mars and Jupiter and came back. That was so, and we now use PCR as if it was nothing. It's water. It's water in our life, right? So I think that, beginning with obviously ultrasound, I started with a 3D ultrasound with a box that was literally this big in 1979, and it was static, and it went ka-chunk, 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 ka-chunk. And we only did that to identify and confirm that there was indeed a pregnancy and that there was a fetus inside. And we did our amniocentesis blindly. We did not use ultrasound. And it really wasn't until sort of the mid-'80s maybe that we were engaged with the idea that we would use real-time ultrasound to guide our amnios. And so now we're doing 3D and we're doing 4D. We do fetal MRIs, we do CT scans. The diagnostic procedures, amniocentesis, chorionic villus sampling, and fetal cordoncentesis are not passé. They are still there. We still need this. So this whole idea of I can do all this sort of stuff with, cell-free DNA is still not in prime time right now, although I will say that also is going at warp speed. And I will not be surprised if in the next 3 to 5 years, we will have testing that allows us to do direct molecular testing for certain conditions off of cell-free DNA. We used to do fetal tissue biopsy for skin disorders. Now we have molecular. And then, of course, most recently, and not so recently, really, is fetal surgery, fetal intervention and therapy with the in utero repair of meningomyelocele. But don't forget, really, that we have been doing fetal treatment, in utero fetal treatment, for a very long time. It began in the even late 60s, I guess, early 70s, with in utero fetal transfusion for Rh disease. We've been doing that for a very, very long time. That's fetal intervention, right? That's fetal surgery, right? We've been treating fetal congenital thrombocytopenias with in utero, platelet transfusions. We have, rarely treated some fetal thyroid disorder with in utero treatment for fetal thyroid disease. So we've been doing it. And then, of course, beyond that, there is the really, really prenatal access to the fetus, which is the blastocyst, right? The 5-cell blastomere, and doing pre-implantation genetic diagnosis. But on the other side, as you can see, is the molecular development and the advances of that. And we talked about cytogenetics, biochemistry, still there. I hope that I will convince you that maternal serum screening is not totally passé. There are still, but rarely, conditions for which biochemistry of the amniocytes grown at amniocentesis is still required. But in the old days, prenatal diagnosis of Tay-Sachs was based on biochemistry. We basically cultured the cells and we looked for enzyme activity. Okay. Of course, now we do DNA analysis, but, and then the Human Genome Project, right, is, in the 1991, is it, has also blown us open in terms of understanding our genome. And then, of course, our technology of sequencing, and then now most recently understanding fetal trafficking, so that there's DNA and other stuff between mother and baby that obviously they are talking to each other during pregnancy. And so it's just a magical ride as far as I'm concerned. Next slide, please. Oh, sorry, it's a double slide, sorry. Next slide. Got it. Okay, prenatal screening options. So I think that this is kind of one of my most favorite slides because it actually hopefully graphically tells you that NIPS, or cell-free DNA, has really, really, been very, very positive for us in our ability to at least try to get an idea about an anomalous baby. So cell-free DNA as a prenatal screening tool is available during the entire time in pregnancy. So a really cool example is, you get, we're doing an ultrasound on a 32-weeker, and lo and behold, this baby has a huge Epstein's anomaly, cardiac anomaly, and mom's 39 years old. Femur's a little short, humerus a little bit short. What is the diagnosis? Differential diagnosis 1 through 10, right? It's Down syndrome. Before NIPS, the only way that we can confirm that is to do something that is invasive and therefore risky, right? But we can do NIPS to confirm that diagnosis, okay? And the question is, do you need to do that? Well, what if it was a 23-year-old? Okay, I mean, the whole point is that confirming the diagnosis allows preparation for the family, because it's not just the heart defect that we want to deal with, but there are all these other issues. And so you have the ability and the opportunity to non-invasively provide a diagnosis for the family, to guide them and for us to help them get ready for this baby. And then, these blocks tell you the different timelines at which the prenatal screening is applied. So next slide. So Prenatal imaging, ultrasound remains the most important tool. It is the tool of the MFM or the obstetrician to get a look at the baby early on. We know that 3% of pregnancies will have an abnormal ultrasound. And we also, the studies have demonstrated that it's the surprise, these unexpected. I'm so healthy, I'm so low risk, but 75% of the time it is going to be the surprise of the, quote, low risk family. The 1994 was the first randomized controlled trial about sort of the utilization of ultrasound and demonstrated that, the 35% of the group screen had findings compared to women who didn't have control. I would say that as studies have come through, ultrasound is not the end-all be-all, and the pickup rate is much higher these days, but it is still not the end-all be-all, but it's better than nothing. And I think that, having this information allows us to optimize the management options for the family. From a obstetrical point of view, an early ultrasound is really important for dating the pregnancy. I think that as you pediatricians, and I have neonatologists there, is this baby growth restricted or are dates bad? When we're dealing with twins, are these monodi twins, of which they have a whole different pathway of complications, or are they di twins? The earlier the ultrasound to make that diagnosis, to clarify that, the better it is for all of us in taking care of that pregnancy and those subsequent babies. Next slide. Okay, first trimester. There's a tremendous value in first trimester ultrasounds. It's not just putting it on there and getting a crown rump length and the date and a heartbeat, but as you can see, as early as 11 to 12 weeks, fetal anencephaly is diagnosable. You just do not see the fetal cranium. If you can imagine that we didn't do that until we waited till a 20-week ultrasound to find the anencephalic, what does that mean for the family, for their options, etc.? So here, really, you should, in a first trimester ultrasound, be able to diagnose 100% of the time anencephaly. There are other things, large cystic hygromas, omphalocele, encephaloceles. Some of the really severe limb anomalies can. Sometimes if you actually do get a really good scan, sometimes you can see an early hypoplastic left heart. But as you can see, it's varied between 50 to 99%. And then, when you get down to open neural tube defects, hydrocephalus, skeletal dysplasia, et cetera, that's definitely less, only because developmentally those may not show up until that time, right? So, but something as simple as anencephaly really should be diagnosed in the first trimester. Okay, next slide. So in the world of prenatal diagnosis, we all talk about nuchal translucency and the thickness of the back of the fetal neck as a marker. Traditionally, and it has been used and still continues to be used as part of the calculation for the risk calculation for Down syndrome. So the larger the NT, the greater the odds ratio that this fetus might have Down syndrome. I actually use it as a red flag. It is just a marker that something is up. It may be Down syndrome, but it could be other things. And we do know that skeletal dysplasias can present that way. Fetal hemoglobinopathies can present that way. So I just look at it mainly as a red flag. So next slide. And so I hope that this slide will show you that point, which is when you look at the fetal NT here, that once you get kind of at, here's the break point here, 4.5 to 5.4 millimeters. This is at greater than 99th percentile. We're looking at subsequent, a marker for a major anomaly, a marker for something bad happening, a marker for chromosome abnormality. So this is kind of where we are here. So it is just, I use it as a red flag. Next step, or slide, sorry. And then, and I hope, then this is one of the papers that I use and our fellows, and is kind of our Bible, because that's always the question. When you have a family in whom there has been an increased nuchal and you've done all the workup that you could possibly do, she's had an amnio, the microarray is normal, all, 387, carrier screening genes and et cetera, and everything is normal. The echo is normal. Are there any residual effects, And this is a really good paper, and just basically tells you that when we're at 99, when the nuchal is greater than the 99th percentile, overall, I look at this as relatively reassuring, at least at between 95th and 99th. It's reassuring. Once you get out here, there is some increased risk for any type of impairment, but kind of depending on whether you look at the glass half full or half empty, there is some residual risk, the bigger the NT, but I think overall it still remains reassuring for the family. Next slide. Okay. So we use now, so 2D is your standard, but everybody's going to 3D. You go to the mall, you get your 3D pictures. Every once in a while, there's an anomaly, and we get called. But I find, so when I wear my genetics hat, I find that for families, when we are going to tell a family that we see a cleft lip and palate, what does that visually mean for them? We know what that looks like. And we can show a picture from a book, right? I'm not sure that I even can really figure out what this looks like. But taking a picture of their baby and actually showing this to them, I think is helpful in the counseling for the family. And I think the other thing that I find really important is to, although we can see this cleft lip and palate, it actually shows the normalcy, the other part of the baby, rather than concentrating just on the cleft lip and palate. Because it's very frightening if we sit in counseling, we just talk about the cleft lip and palate. But it's the wholeness of the baby, being able to do a 3D of arms and legs and the little, feet and stuff, I think normalizes and reassures the family while allowing them to also listen to us about this. So I like 3D. 3D is also super important when we find conditions that we're really concerned about. Like, this is a profile of a baby with micrognathia. So for our peds and neonatologists, it's like, oh my God, are we going to be able to intubate this kid? Where is the airway? What is the issue? And again, for us, having a 3D of what this mouth looks like, so this is microstomia. Do we know that this is microstomia, or is it because there's, auriculocondylar stenosis here? And so helps guide all of us as a team, right, in taking care of this baby. Next slide. And so what we did is, using this information, we can help guide the delivery and the intubation of this baby through something called an exit procedure, so that we basically keep the baby on placental bypass, allow our PENT and neonatologist to secure airway, so that we have this baby. This baby actually needed to be trached while on bypass, but that's, so this is can I say, is this prenatal or intrapartum ECMO? I don't know. But anyway, or it's bypass. Okay. So next slide. So other things, other screening modalities, fetal MRI. I know that, you guys all think about, you are the recipient of an anticipated baby with anomalies, neurotube defect, congenital diaphragmatic hernia, etc. The first question is, did you get an MRI? So we do use MRIs, and they are helpful. This is a baby with who had an MRI, who had a large occipital encephalocele. You can see it here. On axial imaging, here's the skull, here's the front of the head, here's the back of the head. You can see the cranial defect here and two bulging cystic structures. This is the same baby because this baby also had many other issues, had all kinds of contractures and skeletal abnormalities that I could not figure out using MRI or ultrasound. And so we use something called a low-dose CT, it's a one-shot CT scan. And depending on how we kind of ramp up and ramp down various measurements, we can actually enhance the skeleton. And through this, it was really helpful for us to identify the hemivertebra. You can actually see all the rib defects, the bifid ribs, the missing ribs. It was also very helpful for us to look at the cervical spine because we noticed on ultrasound that this baby's head never moved in a certain position. And so it was really important for us to figure out whether this neck could possibly move or not because it impacted how we were going to deliver the baby. This was a baby that the family really wanted full intervention, so it allowed our neonatologist to sort of kind of understand what the mobility of the neck was when the baby delivered. Next slide. Okay. Maternal serum screening. Maternal serum screening has been around for a super long time. It is the prototype of prenatal screening. So as you know, it started out in the 1970s with the finding that elevated maternal serum alpha-fetoprotein was associated with open neural tube defects. In 1984, it was discovered that a low maternal serum alpha-fetoprotein was associated with Down syndrome. And from that came the development of a number of additional proteins added to the screen to increase its predictive value, if you will, so that we landed in the early 1990s with what we call the quad screen, and then in around 2000, the integrated screen, which is our first trimester screen, lab draw combined with a second trimester lab draw, with the idea that it really reduced our false negatives and false positive and increased our predictive value. And really, the quad screen or the integrated screen was our mainstay for serum screening for the longest time until NIPS became available. So is it passé? Because nowadays, everybody gets NIPS if they want it. They go to their OB, and basically by 8-9 weeks, they get their viability ultrasound and they get their blood drawn for NIPS, and we're kind of like done. So is there any value to continuing maternal serum screening? Next slide. So there's a lot of debate in the maternal fetal medicine world about this. I will say in transparency, and I'm of the camp that I still believe that there's value in maternal serum screening. But remember that there are 4 proteins involved. There's a really unique pattern to the different types of conditions. But what I want to draw your attention to is Smith-Lemli-Opitz. So Smith-Lemli-Opitz uniquely has a very, very low UE3, and X-linked ichthyosis also has a very low UE3. The loss of the quad screen basically now have not allowed us to look for this. Smith-Lemli-Opitz is a really big deal. Its clinical presentation is highly variable. It can be very severe in prenatal presentation, and we pick it up on ultrasound early or suspect it early, or it can be relatively mild, like something's wrong, but what? This really picks it up, and so we lose that option these days. Next slide. And then I think that the other thing that I will add to that is that as a maternal fetal medicine specialist, the proteins in a quad screen also are placental proteins. And for us, can be a representation of placental function or future placental dysfunction. So we kind of lose that information as well. But there's a hot debate right now about what we're going to be doing. Okay, let's move on to cell-free DNA, which is, what everybody's doing now. The whole principle of cell-free DNA, so the principle of cell-free DNA is that the fetus, the placenta basically sloughs off DNA and it enters the maternal circulation. We actually all have cell-free DNA in our body. They come from apoptosis of our cells, and then there's all this free-floating DNA. So we have it. But the placenta also does that too. But as you know, the placenta is really genetically a surrogate of the fetus. So that DNA also enters the maternal circulation. So how can we sort through, why can we figure that this is fetus and this is mother? And so the whole point is that the size of the cell-free DNA, of fetal DNA, or actually it's always a misnomer, it's really placental DNA, is that the size of the DNA is 147 base pair versus mom's cell-free DNA is 167. And it's that difference in size that allows us to sort of sort through and identify that this is not of maternal origin. And then the principle of the whole thing, very simply, is that I have cell-free DNA in my body. Let's say for chromosome 21, I don't have Down syndrome. So my genomic copies for chromosome 21 is 2, right? Or 2X. If my baby doesn't have Down syndrome, then the fetal or placental DNA entering maternal circulation is also 2X, right? So the ratio is 1. Okay. Whereas if my baby has Down syndrome, I have 3 times more, so there's going to be proportionately more cell-free DNA entering the maternal circulation. And so we do these mathematical plots, right, to figure out, where we are. If we see, 1 point blah, is this noise or is it truly a diagnosis? So that's kind of how we do it. So same thing with monosomy X, is that, I have 2X chromosomes. If my baby is a male, the cell-free DNA will pick up a Y DNA, right? And so that's what actually determines that your fetus is male. But if it shows up that the fetal or the placental fraction of the X chromosome is below the 1-0 line, then, is it noise or is this because this baby has Turner syndrome? Okay, so that's kind of, in principle, how this works. Next slide. Next slide. Okay. So this is a landmark paper by Norton et al., Mary Norton out of San Francisco, that really looks at the utilization of cell-free DNA in the general population. And huge study. And what I wanted to really impart on our audience is that it's good stuff. It is good stuff, but it's not the end-all, be-all. And so if you look at, if you stratify for the types of patients you have, and you look at the performance of cell-free DNA in low-risk women, in other words, these are low-risk women in whom they have had a normal or negative quad screen. The performance of the cell-free DNA in predicting Down syndrome was very, very low. So I think the idea is that, again, it's a great tool for high-risk women because, remember understanding that positive predictive value of a disease is really dependent on the frequency, right, of the disease in the population. So for high-risk women, definitely. For low-risk women, it still performs better. It still performs better than just maternal serum screening, but it's not as clean as you think. And I think that that's really important as we're taking care of our lower risk women with expectations that are a little bit different in terms of, their pregnancy course. Next slide. So I think that the most important piece of information out of this paper is their secondary analysis. And what they were not prepared for but discovered was that there were a number of cases for whom they could not get a diagnosis. It was called a no-call. And it was kind of like it broke out into not having enough DNA to make, a diagnosis with, 95% confidence level, right? And so when they sorted through what they found were a couple of things. One was that there were 6 straightforward trisomies. They were all detected they had positive serum screening, but the cell-free DNA did not pick this up at all. Now, I find that really interesting because then the question is, the trisomy is also affecting the placenta, so that is a function of the placenta, and is this, placental dysfunction. Then there was obviously triploidy, trisomy 16 mosaicism, and some others. But I think that the thing that was very important was that this was what came out of it, this was when we first realized that maternal weight basically affected or was associated with the no-call rate. And this is also kind of where we began to realize that we needed a certain fraction of fetal DNA, placental DNA, to make a diagnosis of a certain confidence level. So for us, when we do cell-free DNA, the labs, all agree that we report out what our fetal fraction is. Okay, next slide. This is also following that paper. This is also a super important paper. So Hagit Shani basically looked at 3,000 plus amnios that were done between 2009 and 2014. And I think the most important thing was that among 220 abnormalities, 43% of those would not have been picked up. Clinically significant genomic changes would not have been picked up by cell-free DNA, okay? Because of the limitations of cell-free DNA to just look for trisomies, okay? I understand now that, all of the companies have what we call expanded cell-free DNA, where there's a whole bunch of microdeletion syndromes that they now screen for. And it's being done. But I think that we have to realize that those conditions are exceedingly rare, and therefore the positive predictive value is concerning, and therefore the false positives will be concerning. Okay. And I'll give you an example. Case in point is that a couple of years ago, we had a 43-year-old patient who did not speak English at all, was a farmer, too busy in the fields. She got cell-free DNA without any consenting. And it came out positive for 20 GQ minus. And what do I do with that? Does the baby have 20 GQ minus? And without an amniocentesis, do I go ahead and do a fetal echo? We tried to talk to her. She didn't understand. She said, I'm too busy. My life is too busy. I'm not going to drive all the way up to Yakima from where I am. It's a 90-minute drive for something that I don't. Or does mom have 20 GQ minus? Do I have to get an echo on her? So I think, those are real life issues. Okay, next slide. Okay, but I will say that, it's great for late pregnancy with birth defects. It avoids invasive procedure. We also, we just have to remember we have to accept the limitations of the results, and that we really it's placental DNA, so it's really a liquid CVS. And so we're really dealing with also the issues of CVS, which is placental mosaicism. Does this really represent the baby, or is it really the placenta? Okay, next slide. So okay, next slide. Okay, so ACOG basically came out with their consensus statement that basically said for a while, cell-free DNA was really limited to high-risk women, but ACOG came out with a consensus statement that really all pregnancies now should be counseled or offered the option of any type of prenatal screening. So, and that's super important to understand because, you know, whether a patient does one or the other, as you guys know, has to do with access, timing, money. Okay. And so you don't want patients to feel that if they can't do a cell-free DNA or can't afford it or whatever, that doing serum screening is an inferior test. You know, it's just as good. It's better than nothing. And I think that that's a super important point because I've had patients in which I counsel and says, well, I don't really want to do the cell-free DNA because actually there are things I don't want to know about that. And they feel like, but then they feel like opting for a quad screen is an inferior test and they're not doing everything that they're supposed to be doing. So it's really offering the whole gamut of options based on the situation of the patient. Okay. The other thing that ACOG says that if you choose one, stick with one. Don't do both. Don't decide to do cell-free DNA and a quad screen or an integrated screen at the same time. Do not do. If one comes out positive, then move through the line. Don't say, oh, I'm going to do the other one because then I'll be... I had one case in which the cell-free DNA was negative, right? But somehow she got a quad screen and it came out positive. And it was like, okay, got to stop there. So, all right. Next slide. The other thing I think that's really important is patients' feedback and reaction. This is a paper that came out that actually said that a third of women who actually had cell-free DNA regretted that. Okay. And here are some of their reasons. A third of them said, you know, I really would have preferred that you limited the scope of the panel to what I really wanted to know or talk to me more about that. They felt that there was misleading information, that there was an inadequate pre-test discussion, and also kind of misleading information about results. And that really had to do with ambiguous results. You know, the negatives were fine, but the ambiguous was not so fine. And again, it all involves, you know, this idea of education, communication, understanding, and scope of your counseling, which I know is really, really onerous. These concepts are so onerous. How do you even talk to a patient about this? Hard, super hard. And so, you know, obviously the suggested improvement is that the mode of offering DNA screening should be reassessed, or that we should spend a little bit more time thinking about, you know, how we counsel our patients, which I understand in a super big, you know, busy practice. We have language barriers, we have education, health literacy barriers. I know that it's really difficult. I forgot to put a slide in there, but the DOH actually has a site that has videos that explains prenatal screening, and they actually explain it in Spanish as well as in YouTube. If you just go on and go DOH prenatal genetic testing, you'll get there, and you'll just click on prenatal testing, and then it just opens up the whole thing for you. So it's not bad. It's actually quite good. So, all right, next slide. So moving forward and thinking, we are moving forward to using cell-free DNA to do Mendelian disorders. So cystic fibrosis is something, if we know the mutations of the parents, we are now, you know, moving in that direction. There are some labs who are able to do that. RH disease, when you have RH incompatibility, rather than doing an amniocentesis, or if dad's not available to see what his RH type is because it's a new father, then we can now actually do RH genotyping of the fetus using cell-free DNA. So more things to come. In the UK, this is very active, actually, using cell-free DNA for prenatal diagnosis of Mendelian disorders. Next slide. Okay, cell-free DNA more than prenatal diagnosis. All of the stuff that we do as a function of prenatal diagnosis actually opens our world into discovery. It's the discovery of embryology. This is a free moment into the window of the developing fetus, both morphologically and also molecularly. It's really incredible. You have the ultrasound these days to actually watch this fetus, but then you now have these molecular pathways and genetic pathways. And in some ways, you can even argue that for those pregnancies with fetal anomalies for which the pregnancies continue, you have a gift in understanding the developmental abnormality of that particular condition over time. And it's a gift, and I don't take it lightly. Okay, next slide. So it first started with this case. So Diana Bianchi is now the head of NICDH. She is, the pioneer of cell-free DNA, and at the time, the lab was doing cell-free DNA for the country. So we sent some samples to her. And lo and behold, we had found some unexpected discoveries, like, whoa, there's something going on. And one of which was that, so this was actually our case. So we sent cell-free DNA on this patient of ours who had had a renal transplant. And it came back that it was male. But she got her 20-week ultrasound, and the sonographer says, "Oh, look at this! You have such a cute girl." It's like, what the hey? So where did the Y chromosome come from? The donor. So that was our first discovery. That whoa, there's other DNA that we're picking up out of this. Okay, and so next slide. From there, unfortunately, it also revealed to us that cell-free DNA was able or is picking up either a malignancy, a current malignancy in the mother, or potentially a future malignancy in the mother. Okay, so, and this is now, so part of it now is that the results come back, and some of the malignancies, the lab will go, whoa, you guys, we are seeing way too much fragments of DNA everywhere. So we call it a splash. It's just everywhere. And so that's our cue that something is up, okay? We recently had a case, actually, where mom had cell-free DNA at, I don't know, around 10 weeks or something like that. And actually the director of the lab called the physician and said, there's something going on. There's just splatter everywhere. There's fragments of DNA everywhere. So she came in, and she also had hyperemesis. So on exam, unfortunately, she had this huge mass in her abdomen, and what it turned out is that she had stage 4 colon cancer. So this stuff is real. Okay, next slide. We also discovered that there are certain things that also resulted in what we call a no-call or low fraction. So for whatever reasons, women who were on anticoagulation seem to have a higher frequency of no-call. So are we doing something to the placenta with anticoagulation? I don't really know. It does not seem to be related to why you were anticoagulated. So whether you were anticoagulated because you had a mechanical valve versus anticoagulated because you had, lupus anticoagulate syndrome, we don't really know. But this is an observation. Next slide. So here we go. Now we're actually using cell-free DNA to track rejection. So the transplant people are doing that. It's very cool. Next slide. The other thing, go back. The other thing is, yes, transplantation. Okay, next slide, sorry. So I think in summary, cell-free DNA does give you early diagnosis, can give you early diagnosis of genetic conditions. It can be, It may give you more information that you would like to know. It can be an early biomarker for maternal health. And now the direction really is that the cell-free DNA is probably a function of maternal fetal signaling with each other, the language for each other, which I think is very cool. And I think that, it begins to be a window into the genetic mechanisms for fetal and maternal conversations in pregnancy and how the mother and the fetus makes adjustments in pregnancy. So that's on the frontier. Next slide. Quickly, pre-implantation genetic diagnosis. We're taking blastocysts. Remember, though, when we do these biopsies, we're still doing, we're not really doing the fetus proper. It's still a surrogate, so it doesn't really tell you for sure that the fetus is or is not affected. Next slide. Next slide. Just a reminder that we still do fetal therapy and through fetal corticentesis. Next slide. Okay, really quickly, just a couple of examples. This is a fetus that has a huge, not only does it have nuchal, but it has hydrops. So here's the fetus, but look at this halo all around the body. So it's completely hydropic. And at the end of the day, we worked it all up for RH and, thalassemias, but it could be metabolic disorders can present this way, parvo, skeletal dysplasias. So she didn't want anything invasive. So her maternal T21 was positive. Her maternal 21 was for trisomy 21. She had a fetal demise at 18 weeks. So the most important thing also, and I tell our residents and our fellows, is that this just tells you that you have 3 copies of chromosome 21. It does not tell you how those 3 copies come, right? So, and that has reproductive implications, because if it's a translocation 21, that can be inherited, right? So you never stop here and say, oh, she had Down syndrome trisomy 21. So the products of conception must undergo, right, formal karyotyping or testing to either sort through whether it's a trisomy 21 for which there's a 1% recurrence risk versus an inherited translocation, right? Next slide. Sex chromosome aneuploidy. I'll go through that really. So we talked a little about monosomy X. So the predictive value for cell-free DNA for Turner syndrome is like 30%. And the reason is the following. We find it more often in our older moms because actually there is, as we get older, there's somatic loss of the X chromosome in our body. And so that colors our reading of the cell-free DNA. So when we get a monosomy X, we have to go through all of this. You have to sort of pregnancy has to get an amniocentesis, mom has to get a karyotype to sort all of this out in the absence of any ultrasound markers for Turner syndrome. Okay, next slide. I think this is another case of a cancer that we picked up. She had type 1 diabetes. She only wanted cell-free DNA. Not much going on. Severe preeclampsia. And she had some noise in her cell-free DNA that we really couldn't figure out. And she did go through a major workup. We did everything, breast, the whole thing, because she had some noise, but we couldn't figure anything out. So, then you wonder, well, maybe it's a reflection of placental dysfunction because she actually developed severe preeclampsia with HELLP syndrome at 35 weeks and delivered. So we repeated her cell-free DNA at 2 weeks postpartum, and it came back again with a lot of noise, so that we couldn't resolve. Next slide. So, and this is next slide. So what happened was when she came back at her 6 weeks postpartum, we found a breast lump. And when we went back and we actually looked at her cell-free DNA, and we actually redrew her blood, and we specifically looked at chromosome 17 and amplified it, there she was positive for her HER2 mutation. Next slide. This I had just talked about, so we can, next slide. So I want to end by saying that this, I hope, shows you the full circle, at least of my work. This is a woman, she was published, but this is a woman in whom we made the prenatal diagnosis here of a rare 6q21 microdeletion, who grew up, and we became pregnant, and we took care of her. She had a baby. She had actually a couple of babies. Unfortunately, 2 of them were affected with the same deletion. So this is kind of full circle. Next slide. This is, again, some of my families. These are identical twins with type 3 OI, who I've known since they were babies, and then they grew up, and each of them have had children. Same with, this is one of my other family, and this is a mom with spinal muscular atrophy type 2, who many, many years ago would have never survived, but here she is, and we took care of her, and she has a healthy daughter. So it's really full circle. Where do you begin in terms of your screening, right? Next slide. So I just end by saying that in terms of fetal prenatal diagnosis and treatment, it takes a village. It really takes a village to make the diagnosis, to care for the family, both medically, emotionally, psychologically, to get that family and that baby taken care of holistically. It also, offers families choices. And so not all families will make that choice of continuing, but at least it gives them choices. And so I will say that from a maternal fetal medicine and surgical perspective, if a family makes a particular choice of not continuing the pregnancy, then the earlier we make that diagnosis, the safer it is for the mother. And as I speak from a surgical point of view in that respect. Next slide. So this is kind of where we are today. Do we start with the adult to find the screening to move in this direction, or do we start with this to move in this direction? Because sometimes we make the diagnosis in the fetus, and in retrospect, we can go back and make the diagnosis on the parents. And I think that's my last slide, I think.